Hello, everyone, and wherever you are in the world, I wish you a happy Tuesday or Wednesday if you're east of Singapore. I hope you're all well and safe. I'm Ravi Agrawal, Managing Editor at Foreign Policy and your host for the next hour. Thank you for joining us today for an FP virtual dialogue. We're bringing together 6 leading health experts from around the world who will help us analyze the fight against the COVID-19 pandemic. They will tell us what's working, why, and how countries can adopt best practices. We're also going to peek into the future to try and learn what countries can do to improve their public health responses to the next pandemic. We have some great guests for you this hour, and we'll be speaking with them 2 at a time across 3 topic areas. To analyze regional approaches to the pandemic, I'll have experts from Sweden and Taiwan. To examine emerging public health lessons, I'll have guests from the Cleveland Clinic and the UN Foundation. And to look at populations that are particularly vulnerable to the coronavirus and its effects, I'll speak with guests from the Red Cross and from AARP. All of that's coming up, but first, some very quick housekeeping notes. You can participate too, and we'd like to hear from you. If you're watching this on Zoom, click on the Q&A button, submit your questions to any of our guests. Just tell us who you are and where you're joining from, and I will try and pose your question to a specific panelist. If you're watching the live stream on YouTube, you can submit your questions on email to events@foreignpolicy.com. And lastly, we encourage you to use the hashtag COVID-19 Global Response when tweeting about this event. So let's get started. I'm going to ask our first 2 guests to unmute themselves and switch on their cameras as we do in these self-directed webinars. I'm excited to introduce those first 2 guests. We have Olivia Wigsell. She is the director at the Ministry of Health and Social Affairs in Sweden. And we also have Dr. Jason Wang. He's the director of the Center for Policy, Outcomes, and Prevention at Stanford. In the past, he has served as the project manager for Taiwan's National Health Insurance Reform Task Force. So perspectives from Sweden and from Taiwan. Welcome, Olivia and Jason.
Thank you very much.
Great, we can see you now. Thank you for joining us. Olivia, let me start with you. There's great interest in what has now come to be known as the Sweden model of dealing with the pandemic, which was basically the state asking people to practice social distancing on a voluntary basis. But that decision, essentially one of building herd immunity, has come at a cost. Sweden has recorded more than 33,000 cases. It's had 4,000 deaths so far, and that's a much higher rate than those in Denmark with 500 deaths or Norway with 235. So has Sweden made the right call?
Yeah, that's a good question, and we will not be able to answer that now because we are in the middle of a pandemic. So we have to, of course, go back then and see what different strategies worked. But I would say that in Sweden, we say there is no unique Swedish way because we, as every other country, we want to save lives and slow down the outbreak. And we have a strategy that's based on specific characteristics of the Swedish society, that we have a mutual trust between authorities, agencies, and the public. So we have a mixture of legislation, recommendations, strong recommendations, of course, educating the people and also raising awareness. But we have, of course, we lean a lot on compliance and responsibility from the public for them to follow our advices, and also the politicians, they are in their turn leaning on the agencies and authorities and their scientific recommendations. And I would say the Swedish way is also to have a quite flexible approach, and we want to change measures when the pandemic evolves. And we have a legislation in place also, which allows us for stricter measures to be taken. But so far, we have not seen the need to use them.
Olivia, I want to bring in Jason, but before I do, that last point you made struck me as interesting. You said that the policy is flexible and that you could implement changes if need be. So what's the criteria? Are you looking at potentially a sharp rise in the number of cases that would then change Sweden's strategy?
We are looking, yes, if we'll have a sharp rise. Now we have a decline of the curve, but also if we have very different burden of disease within the country, if we need to have a regionalized strategy, or if we are measuring how the compliance is in Sweden. So we are measuring, do people follow the strict recommendations not to travel within the countries, the strict recommendations not to work in your business, but to stay at home if you have the possibility to do so, the strict recommendations to not visit or avoid any physical contact with people plus 70 years, etc. And if I would say we see a lack of compliance, we have to use these strict measures. And of course, there are some legislation as well to complement this, as for example, we have banned gatherings of more than 50 people, etc. And we have had also some recommendations and supervision of how restaurants and shops behave to keep the physical distance sharp.
Sure.
So if we are not seeing compliance to regulation, to recommendations, we can use this, sharpen the legislation. But so far we are impressed by the compliance, and even compared to some other countries in the Nordic countries, we can see that we have a good compliance.
Sure. Jason, let me bring you in. Taiwan is one of the real success stories of this pandemic, if there is such a thing. It has recorded only 441 cases so far and 7 deaths. Can you walk us through Taiwan's approach?
Yes, just to remind people, so Taiwan is about 80 miles off the coast of China. It's a democratic country. And because it has two major political parties, and where 75% of the people voted in the last presidential election, that you really need to make sure that whatever policies that you're implementing, it's agreeable to the public. And so Taiwan has not always had the, in terms of dealing with pandemics, the last time Taiwan dealt with SARS, it has learned a lot of important lessons, and including how to quarantine people, how to make people happy about government policies. And so one of the things that I did correctly this time is to recognize the crisis really early, and to take measures to basically, stop the viral spread right off the bat. That includes boarding on airplanes coming from Wuhan as early as January 1st. To check for symptoms and fever from the travelers that were coming from Wuhan. It includes integrating data sets, including the immigration and customs data set, sending in batches to the National Health Insurance data set, where when a doctor is seeing a patient, he or she could recognize that this person just came from Wuhan and will take precautions in terms of wearing masks and PPEs, and also have more of an index of suspicion of checking for COVID-19, and maybe ordering a test for that. And so a lot of these proactive actions really made a difference in the beginning of the crisis. Since SARS in 2003, Taiwan has also amended its Communicable Disease Control Act multiple times, and it's a bipartisan effort. Now, these efforts include mandating these stockpiles for protective equipment, that every single hospital and also the government needs to have a stockpile. That includes integrating several command centers to form the National Health Command Center. It includes the regulation of gatherings, entry and exit of people, traffic, evacuations, and travel restrictions. They also specify penalties for violating home quarantine isolation regulations and hoarding of resources or disseminating rumors or incorrect information. And it will fine institutions for employee behaviors that are not compliant with epidemic control. Also allows for tracking and management of people and geographic locations, reporting of geographic locations that are sort of at the county level in aggregate, and allow the public use of facility to basically make PPEs and medical devices that are necessary for control of the epidemic. So it has taken numerous measures. And one of the things that's most important in this crisis is activating the National Health Command Center, where 100 people gather in one location where data start to come in and decisions are made from the data analytics that are data driven and logical. And so the combination of having logic, the right sequence of carrying out the steps, as well as the right tempo, and articulating to the public on what they're working on is really important in getting the public support.
One of the elements you're both touching on is a notion of a high degree of trust, not only among people within government, in the wider population at large, but also the trust that the people have in a government. And so I want to come to Olivia with that first. Sweden's model seems in part predicated on a high degree of societal trust, but what other elements of Sweden, what other unique aspects in the Sweden model allowed it to take the approach that it has taken so far?
Yeah, I would say yeah, specific things to the model is that we, of course, have also launched a very big reform program for every side effect of the pandemic, like how it affects businesses, how it affects sick leave, elderly people, or schools, etc. So we have had huge investments to reduce the negative side effects, and I think that has led to, maybe has increased the trust between the public and the government, because we are seeing, as many other countries, an increased trust in the public and in the agencies and in the state. We are actually also seeing an increased interest becoming a doctor or a nurse. So it has applicants to the high school, it has increased by 30%, over 30% for young people becoming a nurse. So strangely enough, we have a huge burden of ill health and COVID-19, but still trust and interest in working in the healthcare sector has increased. So that's very good. And also I would say what's characteristic is that we have a good enough, a very open society. So we have I would say a living debate where we have opinions that said us we should go more for a lockdown instead of having these voluntary measures. And that is also something that makes us be able to, rethink all the time. Do we need more lockdown? Do we need to how do we open society, etc.? So I would say that open climate with different, where you can also, even if there's a scientifically based recommendations, you can actually question them. That's very good, but it's also, it's can sometimes lead to a polarized climate, but it's I would say it's a good thing in Sweden as well.
Sure. On trust, one of the elements that often plays into it is also the use of technology, which can be seen both as something that is a real boon in these situations, but can also be seen as something that extends government surveillance or the surveillance of companies. Jason, I want to put this to you because Taiwan has really been at the forefront of utilizing technology in contact tracing. Can you describe to us some of those efforts, what kinds of applications have been used, and how the people have been willing to participate in those missions?
Yes, so there are 2 or 3 different technologies being used, right? One of them is for example, cellular towers, signals from cellular towers. So these that you're already getting from your telephone companies. They use the signals to make sure that you're getting the optimal signals when you make a phone call. So the government use those cellular tower signals to triangulate where people are if somebody's under quarantine. And so that's not GPS, that's cellular tower. So it's basically, it goes away. And so that in some ways protect the privacy. The other thing is that when they combine the immigration and customs data set, they send batch files actually to the National Health Insurance data set for the last 14 days. So they only take the information, the minimal amount of information necessary to basically track your travel history. So that's the 14-day incubation period. And so after that,
and on these apps, is there sort of a sunset clause that after the pandemic is over, the country or the people who have control of these apps, they won't be using that data anymore?
Yes. So the the 14-day batch files that automatically expire after 14 days, right? And then other tracking strategies under the Communicable Disease Control Act and the Special Act, basically government's authorities expire next year, unless it's reauthorized. And so basically, when you activated the National Health Command Center, government has special powers, but then that would disappear after the pandemic. And so it's very well specified by the law. The other thing that you mentioned about trust is that they have daily press conferences at the National Health Command Center where they ask every question of every single reporter, and they're super nice. And also they communicate at the highest levels. So the former vice president at the beginning of the epidemic was an epidemiologist from Johns Hopkins, has a doctorate from Johns Hopkins. And then the current vice president has a Master of Public Health from Harvard. And so, the vice premier also is a preventive medicine doctor. And so, and of course, the minister is just the most patient man there is. I mean, he's so patient. And one of the things about gender and trust also is to be nice to people. So when they quarantine people, they bring people food 3 meals a day. They give them a book. They bring them masks, and they check up on them 3 times a day to make sure they're okay. And if they get sicker, then they triage them through a special route to the hospital. So people really felt that they were being taken care of and not being incarcerated. So there's a difference between we want you to be in quarantine to protect you and to protect the public, then try to lock you up. And it's a very different concept. And Taiwan has just turned it around and make it so that that it's comfortable during quarantine. They bring you food and they pay you now, $33 a day. So you play video games and you watch TV and they pay you. And if you're a foreigner, you go to Taiwan, they house you in a hotel. It's quite comfortable, like $200 a day.
I'm hearing a sound of all the people on this webinar putting in their applications to move to Taiwan right now.
I think what you are telling us, Jason, is an experience from many countries that having these daily press conferences where you report all data and the situation right now, they are really, something that benefits compliance as well as trust, as you say. And for Sweden, we have also those daily conferences, and I think it's about 30% of the population that are looking
Olivia,
at them.
Both of you, these kinds of press conferences, which are also held in the United States, they only tend to work if there is an already pre-existing sort of basis of trust between people and the government, and also not an electorate that is too polarized. But Olivia, Jason brought up an interesting point about how foreigners are treated. And I want to ask you about Sweden's, what it has done for not only foreigners and immigrants, but also immigrant populations or disadvantaged populations within Sweden. How specifically has the government been able to ensure that they don't feel left behind?
Yeah, that's a good question. It has really been considered for in Sweden, because we have a big part of our population are coming from other countries. So we have worked a lot with information and communication on different languages to be inclusive. So at least like 10 or 20 different languages. So also for people working in the elderly care, So everything is translated and transformed to different languages, as well as specific information campaigns directed to urban areas where you have a lot of immigrants, and also different ways of communicating, because we want to also protect the equity aspect within our health system in Sweden. And also some quite a high part of the regions, they have introduced a more generous legislation where immigrants from, for example, Europe, they can seek care on the same conditions as Swedish citizens. So just in this, specific period, we have a more generous
Sure.
accessibility to healthcare sector. But
Sure.
also I would say, Ravi, you asked about specific Swedish conditions, and I would say what we have discovered is that we have quite a strong healthcare system and services, because as you know, as you started to say, we have a heavy burden of COVID-19 patients, but we have for all the time, for all month, we have provided like a surplus of 30% accessibility to intensive care units. So we have had a big, very good preparedness when it comes to providing
Sure.
all people getting sick with, and that's, I think that was something good with our healthcare
Sure.
system in Sweden.
So we're almost out of time on this segment, but I want to ask one more question to both of you, and I'm going to begin with Jason on this. You've both described countries and healthcare systems that are remarkably effective to varying degrees, that are built upon systems of high degrees of trust, and that are based on countries that have populations that are relatively wealthy. I mean, these are, after all, rich countries. But the question I want to ask you both, starting with Jason, is what lessons can be learned from these approaches? So if you are Nigeria or India, what are the two things, I'm going to limit you to two things that you would recommend leaders from those countries should try and replicate in a way that's doable? Jason.
Yeah, I think one of the things that any country could do is to start a command center. In a command center, you could just pull a few computers together and start gathering data. And even if it's local data, for example, from your local county or local hospital, you could begin to understand the epidemiology of your patient population, including who's going to the hospital, how many people are infected, how do you triage the patient flow, even before they get to the clinic. Because if you have data, then you could start to triage people appropriately so it doesn't spread as fast. So that's so I think decisions are better made when there's data and it's data driven. The second thing is that with the data and the data analysis, that you got to start telling people what you're finding, and then how do they change the behavior or to help the government. So it's a combination of people working with the government that's going to contain the viruses. It can't be the government alone. And so communication, articulating what's important. How do people protect themselves and protect others? I think those are the two things that I would recommend.
Sure. Olivia, do you want to weigh in?
Yes, please. I am in line with Jason when it comes to surveillance and data to be early alerted and pinpoint your measures. Very important to have data. And secondly, I would say come back to actually trust and dialogue, because we know our experience from global health and epidemic response in countries that are not that well off, as in Sweden and Taiwan, is that if you have a lack of trust, it's almost impossible. And no matter how much data and professional guidance and experience you have to form a link to you have to make some kind of relationship with the population and increase trust. And we know from response in other countries that if you don't have that trust and if you don't have a health system at all, you will have a very difficult time and coming in with some kind of professional groups trying then to build up the health system and also to gain trust and then it's very difficult to have this openness, compliance, and dialogue. So I would say aim for and invest in trust, and also, of course, then universal health coverage. Have that in place at first, and then you also can combat the outbreaks of virus diseases.
Sure. Well, for our viewers listening in from around the world, especially in the developing world and countries that are not rich, that's a terrific set of advice from both of you, to begin with data, to focus on clear communication, and in the longer term, to build universal healthcare systems and more trust between governments and their societies. Dr. Jason Wang, Olivia Wigzell, I thank you both very much for joining us for this first section of our FP virtual dialogue. Jason, I know that you have clinic this morning, so you're going to log off and see to more important things than speaking with us. So I thank you especially for making time for us. And you can go ahead and switch off your camera and your mic. Olivia, we will see you again in about 30 minutes or so at the end of this discussion, because we will be taking questions from our viewers around the world, and we will put some of them to you. So once again, Jason and Olivia, thank you very much for your participation so far. And please do go ahead and switch off your video cameras and your mics. Thank you.
Thank you.
Thank you.
And with that, I'm going to ask my next guests to switch on their cameras and their microphones as we continue this webinar on lessons that the world can learn from various countries and best practices to dealing with the coronavirus pandemic. Our next two panelists, I'm very glad to introduce. They will help us shed more light on what some emerging public health lessons are that we can glean from the pandemic so far, from a medical and healthcare perspective, as well as the point of view of global health. And so I'm joined by Kate Dodson. She is the Vice President of Global Health at the UN Foundation. Welcome, Kate.
Thank you. Pleasure to be here.
Great to have you on. And I'm also happy to welcome Dr. Nizar Zain. He is the Chairman of Global Patient Service and a Professor of Medicine at the Cleveland Clinic. Nizar, Kate, welcome to both of you. Thank you for joining us. Terrific. Well, Kate, I'm going to start with you. And, you know, in a world that's trending toward protectionism, nationalism, what does the pandemic reveal about the importance of international organizations and the challenges they face?
Well, it reveals a lot. And I think we've learned a lot in the past handful of months as this pandemic has become more acute. First, the most important thing, obviously, that this disease and other diseases don't respect borders. A set of solutions in one country, like in Sweden or Taiwan, is certainly necessary, but it is insufficient if not all countries are supported to suppress transmission. This pandemic has tested the strength of multilateral institutions, especially the World Health Organization, which has benefited from significant reform efforts in the last handful of years, which have made it stronger and more nimble on health emergencies than ever before. And it's proven that value. WHO has proven that value, I think, tenfold in the course of this pandemic, to be nimble, anticipatory, and relevant as a part of the global solution set on a pandemic like this. They're working on global supply chain logistics, global research and development agenda, support together with other partners in the UN system, other frontline partners like the Red Cross, which Esperanza will speak, towards humanitarian populations in humanitarian contexts. So although multilateral institutions have been tested like never before in the context of this pandemic, I think they're proving themselves to be resilient. And we talked about trust before, but I think the trust in those institutions amongst global policymakers is quite high. Last week was the first ever World Health Assembly held virtually, focused on COVID. Health ministers around the world and more than a dozen heads of state came together. Overwhelmingly, the message that you heard from last week's session was about global solidarity, global cooperation to try to get in front of this pandemic. And I think that message is resonating strongly.
That's good to know. And I want to remind our many hundreds of viewers from around the world that you can participate in this discussion. We've saved some time right at the end where we're going to welcome all of the guests who've been on so far to answer your questions. So please, if you're on Zoom, hit the Q&A button, send in a question, tell us where you're writing from and who you're directing your question at, and I will do my best to put that question to that particular person. If you're watching this on YouTube, you can email us at events@foreignpolicy.com. Nizar, I'd like to bring you in now. What are some of the best preventive strategies that public health officials have employed to limit the spread of coronavirus so far?
Thank you, Ravi. I think there are many lessons learned, but one of the most important that prevented spread of infection is sharing information, and sharing information in the most transparent and timely way. This actually probably saved more life than anything else. This also tag on to what Kate just said. In order to share information across borders in a transparent way, when you have an epidemic that clearly does not respect borders, is actually an important role for a global organization that can take on these information coming from every corner of the globe and share it as well as share the experiences. So that would be number one. The second aspect of it is I think lessons learned that people and countries often during crisis tend to do the right thing. There are many examples globally in which resources of difficult to find items such as PPEs, personal protective equipment, such as ventilators, such as financial aid, things that were hard to come by in some places due to the volume of the patients infected with COVID-19 and the significance of the epidemic. They were shared across borders and often at no cost. I think this is another aspect in which globally had saved significant lives. Then finally, very important, I would say, contribute to saving lives and preventing persistence or recurrence of these surges of the epidemic is the collaboration in science. So there have been many examples also in which testing of medications, vaccines, looking at platforms in which we can share information that will prevent, to diagnose and trace and follow infection. All these items have been shared globally, and sharing ability to perform scientific research really benefit the globe at large. So these are some examples that clearly highlight the fact that we are all in it together, that it is viral epidemics do not respect not only geographic borders, but do not differentiate based on color, religion, or ethnic background, and that we all could benefit by working together.
But Nizar, I want to push back a little bit on some of the things you said, because there still are many countries and states within countries that are suffering from a real shortage of PPE. And that is something that could have been mitigated. I'm going to put that aspect now to Kate, actually, because Kate, I want to get your take on, what are the sort of best practices that were adopted to make sure that PPE and other equipment reached all the countries that needed it? And what were the things that went wrong? Because clearly, again, there are places that are even now are suffering from severe shortages.
It's a great question. And I think this is one of the places, as Nizar was mentioning, there's innovation kind of still going and learning that's still happening. So, and a lot of new systems and structures are being put into place to more efficiently and at lower cost get vital health commodities like PPE, like ventilators, like tests and testing kits to the communities that need it most, not just the countries that need it most, to your point, Ravi. And I think that's, what we saw at the beginning of this pandemic was an incredibly disorganized supply chain and procurement approaches at first. Take the United States, with cities, states, the federal government all vying to purchase, hoard, claim supplies like PPE early on. That was playing out at a global level as well, with countries that had less capacity and less ability to pay, suffering for lack of access to those vital health commodities early on, and navigating supply chains that frankly were largely broken because of the kind of restrictions in flow of people and goods due to travel and trade restrictions that were a necessary part of this pandemic response. So more recently, in the last month or so, the UN has set up a supply chain task force, which is led by the World Health Organization, together with the World Food Program, UNICEF, others that have capacity not only in global procurement of things like vaccines. UNICEF procures 45% of the world's vaccines on behalf of lower resource countries, but also in distribution and supply chain management and reestablishing air bridges. 130 countries have already opted into this set of solutions on this new supply chain task force as the most effective, cost-effective, and efficient way to get vital health commodities, from ventilators to PPE to test and testing kits to community level. And it's starting to work. I think we're starting to see some unlocking with greater purchasing power, with more efficient distribution models to get these health commodities to communities that need it most.
Can you give us an example? Can you give us an example of a place, country, community that has benefited from what you're describing?
So about 2 weeks ago, together with the African Union, Africa CDC and others, the World Health Organization and World Food Program set up what they called the first network of solidarity flights. So based in a distribution hub in Addis Ababa, where a lot of supplies had been aggregated, World Food Program ran flights to every country on the continent over the course of about 2 weeks and distributed millions of pieces of equipment. And that, I think, eased a tremendous bottleneck that was being faced by most of those countries in Africa. That was almost kind of like a down payment, because those needs are ongoing. Obviously, PPE needs are not just a one-time only solution. They're going to be needed over the course of many months. So that was kind of the trial effort to get this whole exercise going. And I think we'll see it scale up over the course of the next several months, with new financing coming in to be able to support this effort, and countries starting to repay when they can, increasing the collective purchasing power overall.
Sure. Nizar, I want to talk about healthcare workers, because obviously they're at the forefront of the fight against the coronavirus, and there have been fears that many of them aren't prepared. They don't have PPE in some cases, or even the right education about how best to prepare themselves. Hospital administration systems have often been called into question again, especially in the developing world. What are the best practices you've seen? What are the worst ones you've seen? What are the takeaways?
Yeah, thank you. Before I answer your question, Ravi, I have one quick final comment about the previous topic.
Sure.
That is, as Kate is talking about these programs to share globally, one lesson I think can easily be learned, that epidemics have major political ramifications, and accordingly, we often see in countries and places that the way is being led by politicians, not public health professionals. I think this is a problem, and it can be, without dwelling too much on details, politicians tend to think locally in their region, country, whatever. Public health professionals tend to think globally. So I think this has been one of the probably obstacles for what you brought up, as far as some places continue to lack access to certain resources, despite these resources being maybe available somewhere else, but they are not getting it. So we'll leave that as such, and we'll go back to healthcare professionals like myself. So I think some of the best practices I clearly would credit organizations like Cleveland Clinic, like my own organization, that have put forward. One of the lessons learned is that the capabilities and resources available within at least the United States healthcare system is very much different from one organization to another. So we have been lucky as a Cleveland Clinic to have uh, uh, broad outreach and significant sound financial books when we started the COVID epidemic. So we were more resilient than others. But for caregiver, it became very obvious very early on in the COVID epidemic that the problem will only be multiplied multiple folds if we start losing healthcare professionals to either COVID-19 or to the psychosocial aspects of COVID-19. So accordingly, there were significant effort being put into management of PPEs. So there's difference between we did not have access to get as many PPEs as we needed, but we were able of managing PPEs, such as limiting number of, of course, canceling elective procedures, and then looking at different ways to re-sterilize certain pieces of the PPEs, and limiting the number of healthcare professionals caring for patients in certain locations of the hospital, so we minimize the use of PPEs. So management was a key. And accordingly, we do not have a single healthcare professional that was exposed to COVID-19 due to lack of PPEs. And in fact, when we look now backward, the rate of exposure and infection among our 60,000 employees in our healthcare system is actually lower than that of the communities we live in. So in a sense, if you worked at this healthcare facility, you were less likely to get COVID-19 than if you did not. So that was what I would call it very good responsible management of PPEs. The second piece of it was the psychosocial aspect. So our leadership early on had many reassuring messages that they actually were not just messages, but truly they followed through with it, that nobody lost their job, that yes, you could work from home and you continue to get paid. So people did not have to worry about day-to-day management of their livelihood. And then they created a team of psychiatrists, psychologists, and primary physicians to support caregivers who are now the frontline providers for patients during the COVID-19. And in fact, apparently, I don't have the numbers, but we had received much more requests for consultations and support from our psychiatry and psychology colleagues from our own caregivers. So clearly people were going through a lot of stress, but having that venue allowed people to manage these psychosocial aspects. So if you talk about best practices, I would say it is really with pride. You could stand in front of I don't know how many people listening to us and say, if you work at this organization, you are less likely to get COVID-19, and if you are really upset and stressed about it, we have resources available to help you manage your stress.
Thank you for that, Nizar. I mean, of course, you're at a wealthy institution that can afford to put in place these measures. If only that were the case everywhere. Kate, I want to ask you about data, because, and Nizar touched on this as well, as did our previous guests. So much of what we're talking about is dependent on the availability of good data, following, after which you analyze and distribute and ensure that the data is transparent and trusted and respected. What are some of the biggest issues surrounding data collection and utilization that you see And what can be done now across countries to collect and manage public health data in a better way?
So yes, and I'm grateful that colleagues have already spoken to this issue a couple of times before, but I think what we're learning about COVID and this pandemic is that it's putting in stark relief pre-existing challenges on data access, quality, and use that are hampering our collective efforts on the Sustainable Development Goals overall, not just on pandemic response efforts in light of COVID. First of all, millions of people are already not counted. They're missed in household surveys or official data systems, and therefore they're missed in the design of effective development policies, or in this case, pandemic response policies by governments and others. That's a matter of data exclusion. Disaggregated data is another challenge by gender, age, race, ethnicity. That hinders appropriate identification of underserved populations and also the ability to design tailored policies and programs to meet those communities' needs. So those were pre-existing challenges. They've been vexing communities and countries for a long time, and there's a lot of energy being put forward by many to try to help support countries to design more nimble, quality data systems and frankly effective use of those systems and the data that is generated from them to better design development policies in general, including in health. But innovation is happening. It's happening everywhere in the context of this pandemic, and it's happening in the data space as well. Jason earlier spoke about public health, the use of mobile phone and as a tool for communication and tracking and understanding contact tracing. But it's also being used in aggregate, anonymized mobile phone data to monitor the flow of people and movement of people as lockdown strategies are starting to be eased. For instance, Ghana is building on work that was previously supported by the Global Partnership for Sustainable Development Data, which is housed at the UN Foundation where I work, on using mobile phone data to determine the relationship between easing lockdown restrictions and the movement of people, which if you tie it to epidemiology data can help identify if those lockdown strategies should be scaled back, can be continued, can go one step further in a phased approach. And strategies like that are incredibly important in these next chapters of this pandemic. Another promising new effort, Vital Strategies with the World Health Organization is working in the African Union and the Africa CDC on a new technical package of support to national governments to more rapidly surveil for all-cause mortality. Because both we know that there's an under-testing of COVID patients, which means we are undercounting COVID deaths. That's nearly a universal problem. But also probably undercounting the indirect COVID-related deaths, people who don't have access to essential healthcare services for their chronic or acute needs, and therefore we're losing them sooner and prematurely. So tracking that on a more regular basis, on a weekly basis through some rapid surveillance techniques can yield a more nimble public health response that I think is really important for this next chapter as well.
That's great advice, Kate. Unfortunately, that's all the time we have for this particular part of our virtual dialogue. So I'm going to thank you, Kate and Nizar, for your excellent insights. Please mute your mics now and turn off your video, but stay with us because we want to bring you back on camera for our Q&A shortly. But before we get to that, we have our final segment where we want to take a look at how the coronavirus has exacerbated existing health challenges and social inequities, specifically on vulnerable populations around the world, populations that had pre-existing reasons to already have a very unequal access to healthcare. And so I have two, again, terrific guests who are very well placed to speak to those inequities and best practices toward dealing with those problems. If I can ask both of them to now switch on their video cameras and unmute themselves. We have Esperanza Martinez. She is the head of health at the ICRC, the Red Cross. And we have Dr. Erwin Tan. He's the Director of Thought Leadership for Health at AARP, which is focused on Americans who are above the age of 50. Welcome to both of you. Thank you so much for joining us.
Thank you for having us.
Thank you.
Okay, terrific. Esperanza, I'm going to begin with you on this part of our webinar. And I want to ask you about the challenges that vulnerable populations around the world face under normal circumstances. So refugee populations, populations that are displaced or otherwise vulnerable. Give us a lay of the land of how serious those concerns are.
So Ravi, I just think to give a little bit of a background on how big the problem is, the International Committee of the Red Cross is mandated to work as a humanitarian organization only in countries affected by armed conflict, war, or violence. And we are present in more than 100 countries, and we run health programs in more than 80. So just to give a sense of the size of the problem. And therefore, the volume of people, the millions of people that today are displaced because of war or armed conflict is huge. And therefore, you find this COVID-19 as an additional menace, an additional threat to their lives and their livelihoods. There are people that already are without homes, many of them, that are already living in overcrowded conditions, either in the fringes of cities or in IDP or refugee camps. There are very often communities that have very little access to essential health services, basic infrastructure, water and sanitation, or healthcare, and very often affected as well by malnutrition or chronic conditions that haven't been treated for months or for years because of the lack of access to healthcare. So just to keep in mind that the COVID-19 is an additional, a compounding situation on these communities, which makes it really hard for them to cope and to basically mount trigger the resilience mechanisms to cope with it.
Of course, and it's so much harder for them to also shelter at home if they have homes, to socially distance, to be able to access food and water. Many of them don't have regular incomes. They tend to be daily wage laborers in many cases, so very hard for them to do the things that you and I are doing, obviously, in this moment. Erwin, I want to bring you in because we've seen the pandemic have a disproportionate impact on older adults. With notable concentrations of deaths occurring in long-term care facilities. What are some of the key vulnerabilities in these types of care facilities, and how do you mitigate those risks going forward?
Ravi, thank you for having me. At AARP, we are very much concerned about the disproportionate number of deaths that have occurred among long-term care facilities and nursing homes. As the U.S. approaches 100,000, in terms of deaths in the US from COVID-19, we know that a third of those deaths have occurred in nursing homes, and that's both the residents and the workers there. COVID-19 has a disproportionate impact in terms of serious illness and death, people who are older and people with chronic diseases. And that is just magnified within a nursing home long-term care facility. And what we see is that this disease is basically multiplying risk factors for mortality and death. One of the things that I think we're very much concerned about at AARP is the infection control within these facilities, information so that families can make better decisions about whether to keep a family member in the facility that's at risk, and also the training. A third of those deaths are both the residents and the workers, and making sure that the people who are essential workers, not only doctors and physicians, but people who are janitorial staff and allied healthcare workers, that they are also trained and protected is critical. And many of those individuals are also not only underpaid, but also part of another community with the United States that is at high risk for serious illness and disease. And that's the inordinate number of deaths that have occurred in communities that are African-American, Black, and also our Hispanic Latino communities as well. And that's just another sign of that, just as this disease has no borders internationally, that within communities within the US, there's a need to make sure that, that we address all the people who are vulnerable. And there it's making sure that not only that we have resources for those who are most vulnerable, but in addition to the healthcare workers that we talked about, that those include essential workers who then also are living within communities often multi-generational homes, and making sure that everyone who is at risk is identified not only by their age or by their chronic condition, but also by their life stage. We know, for example, also that among the 40 million family caregivers in the US, about a fourth of them are millennials. So identifying people through their life stages, but going back to this idea of the nursing homes, making sure that where we know that there is excess and disproportionate number of deaths, that we include, that we provide information so people can make better decisions, training for the people who are at risk, especially the essential workers, and resources such as protective equipment.
Sure. Esperanza, you gave us a great overview of the regular sort of troubles that organizations such as yours face dealing with vulnerable populations. Let's talk about the here and now. Now, what are the biggest challenges that the Red Cross faces in providing health-related services in this moment, and what actions should be prioritized and by whom?
I think there are two different angles to that question. So one is the challenges faced by humanitarian agencies that are several of those challenges are similar to the challenges faced by governments and ministries of health. The lack of or the scarcity of personal protection equipment, the restrictive measures on travel, for example, that don't allow the movement of health personnel to be able to reach communities at risk and so on. But I think that the biggest challenge is that we are talking about a global phenomenon, but with very clear disparity between countries. We do have many countries today that are unable, the health systems are unable to cope with a crisis like this. Health systems that were already unable to cope with the basic needs of the populations and that faced with an additional threat are basically not able to respond to those increased level of needs. So that the here and now, it's both a humanitarian concern, but also it's a global concern. Because unless we strengthen or find ways globally to strengthen those health systems, this phenomenon, COVID-19 or another pathogen, is going to keep repeating. So therefore, there is a need to invest in the elements that make possible basic infection prevention and control. What is so interesting is that when we look at the evolution of this pandemic, we had the conversations, for example, in Europe and in developed countries that were focused on the number of ICU beds, of the number of ventilators. And then when we moved to countries in Africa or the Middle East and countries at war, basically the conversations are about not water to do basic infection prevention and control, no basic health facilities to be able to treat even the milder cases. And now we are seeing the aftermath of the pandemic, and is the fact that several of the routine programs, for example, vaccination programs for children, are being dismantled or are being suspended because basically they are not able to operate in the middle of this crisis. So I think we have too many flanks opened that from a health perspective are only going to increase, not only because of COVID-19, but because this is on top of already weakened health systems.
Sure. And Esperanza, you know, we've been talking about best practices from Sweden and from Taiwan. What's your reaction to sort of even listening to those best practices? Because I imagine in many of the countries that you work in, you can't even begin to apply those things. I mean, are there lessons to be learned?
Well, I found two sentences. Jason mentioned the fact that people feel cared for rather than confined. And we have examples in many countries where basically people that were breaking down the curfew because they needed to go and try to find some food for the children because what they earn daily is what they can eat. They were basically put into detention centers more than isolation centers. So it's excessive use of force on communities, but basically have to choose between physical distancing on basically survival. So we do have these disparities. And yes, of course, we need to be mindful that every context is different. And we have many contexts today in Earth that they don't have these safety nets, where there are pockets of population that basically are on survival mode. And when a threat like this, like COVID-19 hits, it's not only a health emergency, it's a socioeconomic emergency for those communities. So this needs to be taken into consideration. And the socioeconomic impact of this crisis is going to go beyond the macro and the national economies. It's really going to impact millions of people that today have lost their jobs and their capacities to survive. So that's one element. The second element is trust. And I completely agree. You need to have an element of trust to be able to say to the communities, to the people that you basically have around you and say, these are the measures and we are going to implement them because with that, we're going to save lives. But very often in the countries where we work, several of those authorities are parties to a conflict. So basically they are very, very difficult to trust by segments of the community. So that's where the humanitarian action plays a very critical role. Actors that are able to act as mediators, not only humanitarian workers, but very often religious leaders, political leaders, community leaders that are able to bring and grasp that trust and are able to serve as conduits to do basic prevention measures and dissemination of information. So trust is still at the core of it, but it might move from the national level to that grassroots level in this kind of context.
Sure, and as we've been discussing, without trust, many of the best practices don't work as well as they would without trust within a society and between a government and its electorate. Erwin, I want to ask you about the issue of loneliness. I mean, with sheltering in place orders and other restrictions, a lot of older people especially, this compounds their loneliness and isolation that they're already experiencing. What are some of the key interventions that can be made to address this, particularly when for those populations, technology access and use is already a hurdle?
So I'm glad you brought that up. The ARP Foundation recently funded a consensus report by the National Academy of Medicine on the health impact of loneliness and social isolation. And we found that even before COVID-19, that 40% of Americans were experiencing some level of social isolation, and that has only greatly magnified. We know that also that this is a serious health concern because there are some measures that suggest that being lonely is the equivalent of smoking 15 cigarettes a day. And it's to a point where in some countries like the UK, there's actually a ministry of loneliness to address this issue. And this has only been compounded by the necessary physical distancing that's occurred with COVID-19. And I would say that I like the term physical distancing because that's really what we need to consider, that we can still be socially connected without being physically distant. Technology is key. And having, being able to communicate via video conferencing with my own mother, who's turning 80 this year, has been invaluable. And also being able to coordinate with caregivers and physicians at this time is also, and nurses is also important as well. But there is always concern that whenever we have new interventions, that those most able to access interventions are the ones who will do so first. And that only serves to drive the issue of disparities. So we have an opportunity, I think, to leapfrog, to expand the ability to communicate virtually, to have healthcare be transformed by telemedicine. But as we do so, I think ARP has been very concerned about this issue of the digital divide, as we call it, where some communities are very well connected, but others are not. And that includes questions about who is comfortable with technology. And I think there's opportunities there for people to help their neighbors, to help their family members. One of the things that ARP has done is an idea called community connection. And if you Google ARP COVID-19, you'll see that there are opportunities to volunteer to help other people. And one of the issues that we are trying to address is this issue of loneliness. So as we talk about trust and this expectation of reciprocal action, this idea of social capital, as it were, I think that that the ability to connect and not be isolated is important, and to realize that it is a very critical piece to our health, and even more so as people are contemplating, grieving, and as our traditional ways that we mourn have been disrupted by physical distancing.
And that's a sort of virtual companionship that you're describing, right?
Yes, and that rituals can also be transformed to virtual rituals as well. If people who have family members who have passed away, that we can consider doing virtual memorials, that we can do activities while keeping even a phone or a video link on. But I think that the key is that just as we have adapted the medical system to telehealth, that we increasingly have to address this as a problem and realize that that social connections are important in fighting the social isolation. And someone else mentioned this concern, especially for caregivers, of depression, mental health, and grieving.
So we're almost out of time on this part of our virtual session, but Esperanza, I'm going to put one final quick question to you just about migrant workers, because this pandemic has put a lot of pressure on migrant workers because, often in the countries in which they work, they don't have, the best life conditions or access to not only healthcare, but even the judiciary or other social aspects that citizens of those countries may have. What is the Red Cross and other organizations, what are you able to do to help those populations in this time?
So basically, the situation of migrant workers I think is further compounded by stigmatization. Many of them are seen as carriers of the disease, as it was seen as a foreign element. And therefore, many of them suffer stigmatization, beside the fact that they didn't have any safety nets. Many of them don't have any medical insurance. They were coming from countries already where the conditions were poor, and many of them have moved back to their countries of origin, even if those countries are affected by war or affected by violence. So there is a double vulnerability there, not only because of the fact that they lost their jobs, but because very often they are back into communities that themselves are quite poor and quite deprived of the essential services. And we see these examples in the media every day of many different countries where migrant workers have been laid off and they basically have to make their way walking or in very poor conditions back to communities that they left in the first place because there were no economic opportunities. So I come back to my original point. The COVID-19 is a health crisis and a socioeconomic crisis. And we need to evaluate both aspects when we move forward and we take the lessons learned, and because both aspects will need to be factored in. Now, what we do, and as humanitarian organizations and in general, many agencies are trying to do is really focus on the basics, no? Making sure that they do have access to food, that they do have access to shelter. But those are emergency responses. More longer-term actions will be needed in this case.
Sure. Okay, Esperanza, Erwin, thank you very much. I'm going to end this part of the discussion now and move to questions and answers. So both of you, please do stay with us. But I'd also like to re-welcome Olivia, Kate, and Nizar to unmute their computers, turn on their videos, and rejoin us on screen for the final part of this discussion. Jason, unfortunately, will not be joining us because he is at his clinic. So I'm now going to pose some of the questions we've gotten from our viewers so far. And again, if you have not sent in questions yet and you would like to, the instructions are up on the screen right now. Hit the Q&A button on Zoom or email events@foreignpolicy.com and send us a question. Tell us who you are, where you're writing in from, and also who you are directing your question at, and I will pose the question. So Kate, I'll start with you here. There's a question for you from Shumela Fatima, and she asks, how can international health organizations deal with the challenges due to government's lack of compliance with globally established best practices? Kate.
That's a phenomenal question, and one that has been challenging over the past handful of months in this pandemic. For instance, the World Health Organization has issued more than 90 pieces of technical guidance, and anything from how to safely manage schools or in workplace settings to clinical case management, et cetera. It is a voluntary effort at community level, at city level, at country level for governments to take up that guidance. And there's only so much that an international organization can do to try to enhance and incent the uptake of that good evidence-based technical guidance. So I think there are certain limitations, but international organizations are doing a lot to try to build trust in them, in the evidence that they put forward, in the technical guidance that they put forward, and that's a solution there to try to incent uptake. I think one of the other challenges also in the context of the World Health Organization is the international health regulations, which many will know is a global public health and international law signed on to by most member states, by most governments of the world. That requires certain responsibilities that governments have to report adverse events, outbreaks of unknown origin, et cetera, to the World Health Organization. WHO, by established in international law, only has certain authoritative powers to try to draw in a member state to comply and report, but it's really incumbent on that member state to do it in first instance. So there certainly are limitations to the power, the kind of power of the stick, especially of international organizations. And so WHO, among others, is trying to use the power of the carrot as much as they can.
Sure, thank you. I have a question from Dominic Chan. This is not directed at anyone in particular, but I'm going to see if maybe Esperanza or Nizar would like to try this. And the question is about supply chains. Dominic is asking whether supply chains and production of pharmaceuticals should be decentralized. So for example, should ASEAN have its own supply chains and systems to distribute pharmaceuticals? Nizar, would you like to try and take a stab at that?
Sure. I will give you not a scientific opinion, but I would say in general, the COVID-19 epidemic had highlighted the necessity for some diversification in supply chain that is not only applicable to pharmaceuticals, but also to, again, protective equipment and larger equipment such as ventilators. So this is, I think, is on the mind of every single one. I can tell you that the state of Ohio is building manufacturing facilities for gloves and masks and even for pharmaceuticals. There is one of the lessons learned, I think, is that there is a great need if there is, and there will be other either a COVID-19 or similar pandemics, that we need to stockpile some of these critical elements, and we need to have a supply chain that is more resilient and less likely to fall apart the minute there is a pandemic. So the answer is yes. I think there need to be more diversification of supply chain.
Sure. Anne Stewart asks whether there are effective ways that one can, quote unquote, ground truth the data that comes out from governments, particularly in countries where transparency and free data sharing are a challenge. Esperanza, would you like to tackle that?
I think one of the big challenges, and again, my perspective is coming from countries that are highly affected by fragility and that have very weak health systems, is that you cannot prepare and present good data if you don't have the background work and systems in place. So this is basically like you cannot have prepare a firefighting plan in the middle of a fire. So we really, data and health data systems are part of a larger strengthening of health systems that need to take place. This is not new. The lessons from Ebola taught us that we will need to invest more in those countries that have weak health systems, and here we are. So really, hopefully, this will be another call in which health data systems across many different countries and regions is strengthened. So when a crisis hits, then it's easier to extract the necessary data. But very often it's not that governments don't want to release the data, it's that just basically they don't have the capacity to collect the data in the first place. So we need to keep in mind that element as well, rather than thinking that it's all covering up with data. Very often it's just the data doesn't exist.
Sure. Olivia, I'd like to bring, sorry, go ahead.
I was going to say one word to follow up, that is, I think I agree with Esperanza that the data in COVID-19 as good as testing. If you don't have testing, you don't have data. If you don't have a platform to collect that. So it is linked to a lot of other things. I think we always assume that somebody is hiding data, but it may not be there.
Sure. Olivia, I'd like to bring you in. I have a question from Jorge Saavedra at the Global Public Health Institute at the University of Miami. And he says that there's a focus by the World Health Organization on universal health coverage, such as the UK's NHS as the aspirational model. But he says that the UK, with a 14% case fatality rate, is performing much worse than most developing countries. So why do WHO and others keep insisting that universal healthcare is the solution? Now, obviously, you're in Sweden, you're not a spokesperson for the British government, but more broadly, what do you make of that critique of the public health system model? And how do you think Sweden's could offer a better path forward?
That's a good question, and I suppose there is no direct relationship between universal health coverage and the spread of the virus, because when combating the virus, you have to have more societal measures that goes without the healthcare system. So a strong or a universal health coverage is only a guarantee that when people get ill and have COVID-19, they will be taken care of. And it's also a piece in the puzzle when it comes to building that kind of trust we are discussing here. So I would advocate for universal health coverage in another way, because it promotes the health in a sustainable way for every part of our society or community, like boys and girls and women and men, but it's not the main part of society that combats the spread of the virus.
Sure.
But maybe it is also like this, that this pandemic also shows some gaps that we have in our universal health services and our welfare systems, both in the countries with a strong welfare system, as well as in countries with a weaker welfare system. We have gaps, and those are highlighted to a very high extent now in Sweden when it comes to elderly care, as well as in UK also when it comes to elderly care.
Sure.
May I
We
just-
have a few minutes left, and if you'd still like to send in your questions, again, click on the Q&A button on Zoom or email us at events@foreignpolicy.com. Kate, you wanted to weigh in. Go ahead.
Yeah, I wanted to weigh in on this because I do think we can't undermine the value and importance of universal health coverage in achieving broader sustainable development goals. In countries who have poorer and less strong health systems, especially at primary care level, are ones that are likely to have potentially not just higher COVID-related morbidity and mortality, but also higher morbidity and mortality related to lack of access to essential health services in light of this pandemic, right? If kids are not getting basic immunization services, if women are not getting access to family planning, if people are not accessing, communities and houses aren't accessing malaria prevention and treatment, then all-cause mortality is going to go up. And you need a strong and resilient primary healthcare system tied to a stronger, overall universal health coverage effort at a country level in order to provide those basic essential services, vital not even and only in a pandemic, as well as the pandemic-related services that are specific to COVID.
Erwin, I want to bring you in. There's a growing school of thought that Sweden's model may be the way forward for many countries around the world, where you begin to allow some sort of herd immunity to set in among younger parts of the population while you keep more vulnerable parts of the population at home and still secure and safe, and therefore as far away as possible from the spread of the infection. Just from your perspective, given how closely you deal with the elderly population, if something like that were to be the mode that would be conducted in the United States. What does that mean for elderly populations? And then just to expand on that more globally, what does a herd immunity strategy mean for our parents?
So I think the difficulty with herd immunity is that it's hard to identify individuals who are at risk just by their demographics. I think that as I mentioned earlier, we at AARP often look at your life stage, that if you are living with someone who has a chronic condition, like cancer or diabetes, or if you are a caregiver, and as I mentioned, of the 40 million caregivers in the US, family caregivers, 1 out of 4 is actually a millennial, that you are also at risk. And that the other concern that we have is, as people slowly unwind, as communities are able to unwind physical distancing, we're very much concerned about this issue of age discrimination, that we do not want employers to discriminate against people who they perceive are at risk, and at the same time not identify those who are at risk falsely while they are at risk because of who lives in their homes. So I think that I think the considerations are also important as we look at where we had disproportionate impact of serious illness and mortality, and that's often in communities where African-American, Black, Latino, Hispanic communities in the US. And there you often find some people who are working in what we call essential jobs, where people, because of the paycheck, are feeling that they need to work. And I think it's important to allow people to work if they need to or choose to, but we need to make sure that everyone is able to work safely. And this sort of universal approach to making sure that we all can work safely and participate in the economy is an important piece as well.
Sure. I have time for one last question, and this is from Gail Choate from Boca Raton, Florida. I'm going to put this to Kate, and the question is that each of you has discussed how the current pandemic crisis points out, exaggerates, and exasperates weaknesses in our economic, medical, and social systems. So how do you anticipate or recommend structural changes that will allow us to truly move past this crisis and emerge better and stronger? Kate.
Well, isn't that the $1 million question to conclude this conversation? And I certainly welcome others' thoughts as well. But so I think there are a set of recommendations, certainly investing in stronger primary health care in the context of a larger effort towards universal health coverage is a commitment that every government signed up to last September at a UN high-level meeting. And that needs to be a part of the solution in the next decade as a part of the Sustainable Development Goals, because a more resilient and stronger healthcare system is more likely to withstand the shocks of a pandemic while still being able to provide to the basic healthcare needs of its population. So I think that's one piece. Dr. Tedros, the World Health Organization's Director General, when asked this question last week in his opening to the World Health Assembly, basically said, we don't need a new piece of the global pandemic architecture for response. What we need is to better invest with political capital and resources well placed in the institutions that we already have to make sure they perform to their utmost. And I think that's the key message. If people come out of this pandemic saying we need 18 new layers of pandemic architecture in order to avoid, the trappings of what's happening in this current environment, then we will have failed. What we have to do is better invest, reform, respond to the existing architecture that we have in order to make sure that it is fit not only for present purpose, but future purpose as well.
And Ravi?
Go ahead, Esperanza.
If I could say, strengthening health and health systems also comes with a strengthening sanitation, water and sanitation infrastructure, because we cannot do infection prevention and control without water. And also strengthening the resilience of populations. So really working towards identifying those more vulnerable in the community. Could be older people, could be people with disabilities, people with mental health conditions, but identifying those pockets of population that we know that if the crisis hits are going to be the first ones that will fall off the radar and will be highly affected. So really making sure that there are safety nets or there are provisions in place to continue to ensure their survival and to make sure that they can actually contribute to public health measures and abide by them.
That's a very smart point to make. I'm sorry to have to end this here. It's been a really fascinating and insightful conversation. A big thank you to our roundtable participants, Olivia Wiegzel, Esperanza Martinez, Kate Dodson, Dr. Irwin Tan, Dr. Nizar Zain, and we had Dr. Jason Wang earlier as well. He had to jump off. Thank you to each of you so much for taking the time to share your perspectives with us today. And I wish you the best of luck in each of your respective endeavors to try and find ways to better combat this pandemic that confronts us all. And with that, I'm going to have to close it. I just want to say thank you as well to our audience from around the world, which has joined us and been sending us in questions. The insights that we've heard today will help inform an upcoming FP Analytics special report on countries' responsiveness to COVID-19. And that will further elaborate on some of the themes we've touched on today. It will inform it. Please do come back to us to look at the results of that report. To do so, you need to subscribe to Foreign Policy or to become an insider subscriber. Please stay tuned for more upcoming virtual dialogues here at FP coming up in June. We'll be posting updates and more information on foreignpolicy.com/events. You can also see our older events there and read more about this and all the other issues related to the pandemic at foreignpolicy.com. Thanks everyone for joining us today. I'm Ravi Agrawal, FP's managing editor. Take care, stay well, and see you soon.